Assalamu alaikum. Let's dive into respiratory system where I will discuss about these important five topics. Start with this hypersensitivity pneumonitis. Okay, look at that. Look at this US millionaire circle box. In hypersensitivity pneumonitis, it's an immunologic response. It's an immunologic response to inhaled antigen like mold, animal protein. If you look at its presentation, acute is fever, abrupt onset fever, chills, cough, fatigue. So fever, leukocytosis, episodes of recurrent and self-resolving. Chest X-ray shows scattered micronodular interstitial opacities. Chest X-ray shows scattered micronodular interstitial opacity, very high yield. And in chronic, it may be progressive cough, dyspnea, most importantly, hypoxemia that worsens with exertion. And chest X-ray should diffuse reticular interstitial opacities. So hypersensitive pneumonitis, there is interstitial opacities, there is interstitial opacity. If it is micronodular and scattered, it is acute. If it is diffuse reticular, it is chronic. How to diagnose? Pulmonary function test where we will see respiratory pattern and DLC would be low. Bronchoalveolar lavage, there is high relative lymphocyte count, very high yield. And lung biopsy shows lymphocytic infiltrate and poorly non-caseating granuloma. Poorly non-caseating granuloma. In sarcoidosis, there is non-caseating granuloma too, but in TB, there is caseating granuloma. So in hypersensitivity pneumonitis, another differential where we will get non-caseating granuloma, interstitial inflammation, or fibrosis, chronic only, and treatment remove the antigen exposure results in acute disease and glucocorticoid and a lung transplantation in chronic. Acute symptoms recur and resolves within 1 to 2 days versus infectious cause like pneumonia. Now, if we read this question, a 16-year-old girl is brought to the office after a day of fever, malaise, shortness of breath, chest tightness, productive cough. Her symptoms started after visiting a farm during summer camp. Her symptoms start after visiting a farm during summer camp. The patient says she was feeding hay to the cattle and milking a cow to get farm experience. Her mother recalls that he got sick when visiting another farm several years ago. It took her several days to recover after returning home. Patient has a history of eczema and her brother has asthma. Temperature is 104. There is fever, hypertensive fever, BP normal, pulse is normal. Pulse oximeter 92% when breathing in room air. Lung auscultation, bilateral, fine crackles. Pulse oximetry show decreased forced vital capacity. Looks like restrictive lungs. Which of the following is the most likely? So whenever he visit a farm, whenever he goes to contact with animals, he got some sort of immunologic response, thus causing his sickness. Looks like hypersensitive pneumonitis. In hypersensitive pneumonitis, we have seen that there is interstitial opacity. In both case, in acute and chronic case, there is interstitial opacity, and it is bilateral interstitial opacities. It is not pulmonary bilateral pleural effusion. In pleural effusion, there is decreased, diminished, or absent breath sound, and in percussion, there is a dullness on percussion. Okay, so it is hypersensitivity pneumonitis. So these patients fever, malaise, non-productive cough, dyspnea after visiting a firm is consistent with hypersensitivity pneumonitis. Hypersensitivity pneumonitis, an exaggerated immunologic response to inhaled antigen, molds, animals. Okay, common precipitating agents, certain bacteria are common precipitating agent. Look at here. These are the conditions like chemical workers lung, spray paints, dyes and varnishes, spray paints, dyes and varnishes. These are the causative agents that can cause hypersensitive pneumonitis, like condition farmer's lung, bird facial lung, hot tub lung due to mycobacterium avium, mushroom worker lung, potato riddler lung, thermophilic actinomyces, winemaker's lung, botrytis, cheesemaker's lung, penicillium, and chemical workers lung, spray paints, dyes, varnishes. Okay, HP may be acute, maybe chronic. Look at the X-ray of the acute. There is scattered. There is, look at here, there is scattered micronodular reticular opacity, scattered micronodular reticular opacity in acute cases. But in chronic cases, again interstitial opacity, but diffuse reticular. There is diffuse reticular interstitial opacity, diffuse reticular interstitial opacity. Look at diffuse reticular interstitial opacity. There is honeycombing also. In CT, there is honeycombing also. If there is development of the fibrosis resulting in chronic bronchial and peribronchial inflammation. So that's all about hypersensitive pneumonitis. Look at bilateral pleural effusion. Look at bilateral pleural effusion. It is usually seen in heart failure. Bilateral pleural effusion are often seen in volume overload, heart failure, renal failure. Bilateral pleural effusion. Bilateral pleural effusion. Okay, enlarged heart may be seen in pericardial effusion. Enlarged heart wide versus thoracic diameter. Cardiothoracic ratio is more than 0.5. Cardiothoracic ratio, enlarged cardiac shadow. Cardiothoracic ratio more than 0.5. Okay, hyperinflated lung filled in obstructive pulmonary disease or in asthma exacerbation or in COPD. COPD, hyperinflation more than 8 ribs in seen in COPD, normal cardiac shadow, flattened diaphragm in COPD, and upper lobe infiltrate with cavitation in this upper cavity with gas filled lesion, cavity with gas filled lesion in tuberculosis. So these are the things you should be uh, in your differential before telling that it is hypersensitivity pneumonitis. Okay. Oh, another question regarding this: a 34-year uh, woman comes to the hospital after a day of sudden onset fever, chest tightness, dyspnea, dry cough. The patient has been hospitalized twice in the twice in the past 3 months with similar symptoms. Both times she received antibiotic for pneumonia, and the patient and the symptom resolved within 1 to 2 days. She does not use tobacco, alcohol. She does not use tobacco, alcohol, or illicit Drugs. Okay, temperature is present. Pulse oximetry 90% on room air. This the patient is mild respiratory distress. Examination show normal jugular venous pressure, no lymphadenopathy, diffuse lung crackles, and there is fever, there is leukocytosis, and chest CT show bilateral micronodular interstitial pattern. So looks like bilateral micronodular interstitial pattern looks like it is hypersensitivity pneumonitis. Okay, it is acute HP, acute onset fever, cough, dyspnea, fine crackles, leukocytosis, as well as diffuse bilateral interstitial diffuse, as well as bilateral micronodular interstitial pattern. Looks like hypersensitivity pneumonitis. Our next topic is sarcoidosis. Okay, look at the sarcoidosis. These are the manifestation of sarcoidosis. In pulmonary, there is hilar lymphadenopathy. In pulmonary, this is widened mediastinum due to hilar lymphadenopathy. Look at the lymphadenopathy. Left hilar lymphadenopathy. This is right hilar lymphadenopathy. Hilar lymphadenopathy. Okay, there may be interstitial infiltrate. And another cutaneous symptoms is erythema nodosum. So pulmonary is hilar lymphadenopathy. Cutaneous is erythema nodosum. Ophthalmologic is uveitis, anteroposterior uveitis, conjunctivitis. Sicca. Neurologic is facial seventh nerve palsy, facial nerve palsy, CDI, central diabetes insipidus, where ADH is absent. Give desmopressin. Hypogonadotropic hypogonadism. And cardiac is the AB block, dilated or restrictive cardiomyopathy. GI is hepatosplenomegaly. There may be this one is very high sarcoid and hypercalcemia, parotid gland swelling, polyarthritis, constitute symptom like fever, malaise. So fever, polyarthritis, these are the manifestation of Lofgren syndrome and bilateral erythema nodosum and bilateral hilar lymphadenopathy. These four things are the feature of Lofgren syndrome. In sarcoid, there is plenty of syndrome, but Lofgren is must. So, so in sarcoidosis, common in young uh, African American and females, shortness of breath on examination. Um, with occasional fine rales on exam, no wheezing can be associated with erythematosum. I have told you chest X-ray show hilar adenopathy seen in more than 95%. Lymph node biopsy may show non-caseating granuloma like hypersensitive pneumonitis. Treatment is prednisolone if asymptomatic and do not treat. Although lung involvement hilar lymphadenopathy is common in sarcoidosis, it is often asymptomatic patient may present with extrapulmonary disease. OC is restrictive disease of origin and sarcoidosis. And sarcoidosis are equal to restrictive lung disease, restrictive heart disease is possible. Patient with sarcoidosis who presents with right upper quadrant pain, think about liver involvement, granuloma in liver. So that is all about sarcoidosis. Look at this question. This 30-year-old woman comes to the emergency department. Why? Dizziness, unsteadiness. Okay, good. Near syncopation. Okay. He has uveitis, one of the feature of the sarcoidosis. Okay, treated with topical therapy. Yes. He has not the fever. Pressure is normal. In ECG, showed 2:1 AV block, very high yield AV block in one of the feature. Uh, One of the cardiac manifestation in sarcoidosis, 2:1 AV block and left bundle branch block. And chest X-ray reveals bilateral midfield lung opacity. That means bilateral hilar lymphadenopathy, bilateral midfield lung opacity looks like sarcoidosis. So AV block. So AV block and a left bundle with a left bundle branch block. AV block and a left bundle branch block with bilateral hilar adenopathy looks like sarcoidosis. Okay, a look at here, 30-year-old. Just look at the calcium level. Sarcoidosis can cause hypercalcemia. Look at the chest X-ray, bilateral hilar fullness. So bilateral hilar fullness, hypercalcemia, other feature like shortness of breath, non-productive cough. Looks like sarcoidosis. Glucocorticoid or steroid is the drug of choice. Steroid is the drug of choice. Okay. Our main next topic is pulmonary hypertension. Pulmonary hypertension can be divided into four groups. Group 1, pulmonary arterial hypertension. Group 1, pulmonary arterial hypertension. In here, evaluate for autoimmune connective tissue disease, toxin evaluate for autoimmune connective tissue disease, toxins, acetaminophen, HIV, cystosomes, pulmonary vasodilator therapy. Pulmonary vasodilator therapy treat underlying autoimmune cause. Group 2, left-sided heart disease, echocardiography with or without right heart catheterization if diagnosis is unclear. And optimized left ventricular function heart failure therapy treat significant valve disease. So pulmonary arterial hypertension, left-sided disease, lung disease with chronic hypoxemia, pulmonary function test, chest imaging, polysomnography treat underlying respiratory condition, obstructive sleep apnea, and finally chronic thromboembolic pulmonary hypertension. Chronic thromboembolic pulmonary hypertension, there is DQ scan, pulmonary angiography, pulmonary thromboendarterectomy, surgery, and anticoagulation. General measure refer to accredited pulmonary hypertension center. Refer to accredited pulmonary hypertension center. Maintain normoxia, euvolemia, and sinus rhythm. Contraceptive counseling should be done. Immunization, cardiac rehabilitation, and refractory pulmonary hypertension bilateral lung transplant should be done. Symptoms: decrease cardiac output, exertional symptom, increase pulmonary arterial pressure, chest tightness, right ventricular demand, ischemia, exertional tightness, and venous congestion, abdominal distension, bowel edema, early satiety signs, precordial signs like precordial heave due to right ventricular hypertrophy, very high health, and loud P2, right S3 for hollow systolic murmur of TR. So TR murmur, JVD, ascites, JVD, ascites, and pulmonary edema and hepatomegaly. Okay, this is pulmonary arterial hypertension, enlarged hilar pulmonary artery. How the evaluation a case of pulmonary hypertension, a very, very, very high yield. Suspected pulmonary hypertension, dyspnea, lethargy, fatigue. Do echo. If echo, yes. Left-sided heart disease on echo, yes. Cardiology consultation of left-sided heart disease for further evaluation. No, further evaluation should be done. Considered to based on his history like polysomnography. If there is OSA, can cause pulmonary hypertension. VQ scan to rule out CTEPH. That That means chronic thromboembolism, pulmonary hypertension, pulmonary function test should be done, HIV serology, NA rheumatic factor ANCA in patients with suggestive symptoms, and urine toxicology, amphetamine should be given. If echo shows no high pulmonary hypertension, echo shows no high pulmonary hypertension, clinical suspicion, yes, exercise echo or right-sided heart catheterization, exercise echo or right-sided heart catheterization, abnormal and suggest pulmonary hypertension, consider of the following based. If high pulmonary hypertension suspicion is no, evaluate for other cause. Evaluate for other cause. Okay.